Sujan, you want to introduce Dr. Ferrer again for this presentation?
Tan bueno porque no son. O sí. Anda por ahí porque hay varias personas. No, pero no tengo ni todo, yo no quiero.
Dr. Ferrer, for your next lecture, please come to the desk.
Thank you so much.
Is it on?
Yes.
Yeah. Yes. Get rid of it.
Dr. Gerardo Ferreira holds the position of Chairman and Program Director of Psychiatry Residency Program at Larkin Community Hospital. He's board certified by the American Board of Psychiatry and Neurology and has over 10 years experience in the field of psychiatry. Additionally, he serves as the IRB chairman for Larkin Hospital System.
Yeah, well, no, take it on top.
And then I'm giving it to Dr. Michelle.
Ready? So welcome everyone, and thank you again for being with us today. Now we're going to get into a different topic, very interesting in my field, which is therapeutic advancements in psychiatry. So what are the objectives we're going to discuss today? So, do you hear me? So we're going to discuss the latest therapeutic advancements in the treatment of psychiatry. We're going to understand these recent breakthroughs, emerging therapies and technologies in our field, along with the benefits and challenges that come with these advancements. We're going to discuss the latest approved approaches and those advances in that are advancing in clinical trials. So let's consider how these advancements can help the future and direction of psychiatric care as we go along. So I'll overview. We're going to go over first the psychopharmacological advancements, okay? I'm going to touch upon a little bit about antipsychotics, antidepressants, and then long-acting injectables that we have currently and those who are in clinical trials. Emerging researches with substances like ketamine, psilocybin, MDMA, and CBD, cannabidiol. Some technology like brain stimulation therapies, right, which include ECT, electroconvulsive therapy, transmagnetic stimulation, vagus nerve stimulation, and deep brain stimulation. So advancement in psychiatry, okay. So let's get a little bit to history here, just, touch as I go along so you can understand what's been happening. In the 1950s and 60s is when the first, basically in the 50s, the first generation antipsychotics started to be developed, right? Starting stemming from chromazine, and also we have here the antipsychotics and antidepressants were developed and introduced, but also the sedatives, the benzodiazepines also were introduced during this period. In the 1970s and 80s, there was like more so in the 80s, like a big breakthrough, right, in molecular pharmacology, right? So now we're pinpointing at this point, it was just like, an era of, extreme evolution, having new resources out there for our patients, right? It's starting to evolve, our learning more so with more advanced technology in research labs on how certain areas of the brain work, delineating receptors on the receptors are starting to come out, how the medications affect these receptors, like for example, a big breakthrough in the serotonin reuptake inhibitors, found out, how blocking these receptors, you having more availability of the neurotransmitter in a synaptic cleft, how that can help and regenerate the current and from those neurons. So it was like a big breakthrough revolution, right? But current psychiatric drugs show limited improvement, in overall efficacy. If you really look at it compared to the very first agent. So this is a big breakthrough, right? A lot of things were evolved, but throughout this, 50 years nowadays, we're trying to find other options with medications, limiting, a lot of symptomatology, improving the symptomatology, being really effective. And how's that compared to the ones that we have before, which in reality have a lot of side effects but are effective, right? So yeah, like I was saying, psychotropic drugs with novel mechanism of actions have been rare, right? They've been rare, until like recent years. So evolving knowledge in neuroscience and pharmacogenomics are really key for us to develop new targets for psychopharmacological targets. And emergence of potential newer medications and approaches bring optimism for new treatment modalities. So I was saying in other words. Okay, so advancements in psychopharmacology. So for example, we mentioned, pathology of schizophrenia because it is, a very devastating disorder, right? And it's a disorder that nonetheless, you say, oh, 1%, but 1%, it's 21 million individuals worldwide affected with schizophrenia, okay? And it decreased the life expectancy by 15 years, that disorder per se, right? That disorder will bring a lot of metabolic issues and, risk factors that affects the patients with a lot of morbidity. And, with the development of second generation antipsychotic about 25 years ago, we're able to help limit a lot of the side effects, right? Increasing the efficacy, for example, touching upon all the receptors with these newer medications. You also try to target negative symptoms that they're having, and the tolerability profile, right? One big is extraphenomenal side effects, and attempting to limit that, not being such a strong D2 blocker like a Haldol, the newer medications, the older medications. So, being that said, yes, now we're coming up with medications that can target other symptomatology that the pathology displays, and attempting to have more tolerability, especially in this aspect of extrapiramidal side effect. But what happens with other side effects? What happens with metabolic side effects, right? So it's been shown, for example, clozaril, right, and Zyprexa, they work very well. Okay, their medications have worked exceptional, but the side effect profile is very large. Okay, not just affecting blood discretions and like that, but also it takes it adds on to the metabolic risk that the patient already has embedded with them. Okay, and I was talking in previous presentation about cortisol. Well, in studies have been noticed that schizophrenics since 9, 10, 11 years old, if you measure, they have such a high cortisol, which leads to the paranoia later on and leads to hypertension, cardiovascular risk, diabetes. Okay, so it's not just the medication. So now we have better medications, but also contributing to other factors while we're attempting to limit other side effects. So treatment options have been practically aimed, at blocking the dopamine 2 receptors, right, in the mesolimbic system. Something's happening. Something happened. Okay, I went the wrong way. No, No, okay. Yeah, it's slower internet. It's not coming out, right? Okay, so as yeah, so yeah, as the internet starts to, so this can pop up. Okay, now you got it. Thank you. Okay, so in recent years, then we went far and beyond from what I was saying, right? Because basically the treatment has been aimed as the first generation antipsychotic, blocking dopamine 2 receptors, right? And then with the second generation antipsychotics, elaborating from the other theories of schizophrenia, with serotonin receptors, glutamate theories, acetylcholine. So these newer medications, I'm gonna touch upon these that have come into the market, okay, aiming to work towards all these receptors, right, like cariprazine, the dopamine 3 receptor partial agonist, right? And it was approved in 2015, okay, for schizophrenia and bipolar, and it's pending now even approval for adjunct as a major depressive disorder. And as you can see, now they're aiming to block also receptors, right, which also contribute to decrease the psychotic manifestations, but also improve executive functioning, memory, and decrease the negative symptoms without the detrimental effects of metabolic issues. Are they going to be, really, the light at the end of the tunnel? Well, we're still working on that, because in reality, sometimes you put a patient on one of these medications and it might work, but others that are really severe, you start to notice, wait a minute, well, because in reality, the first generation actually do work very well, Levolve. So this is basically the olanzapine, as I was saying before, that work very well. The olanzapine works very well at Crossfield, but it has a lot of metabolic side effects. I remember when they were trying to adjunct a medication targeting receptors, which actually are the ones that, for example, like olanzapine target, which brings upon these metabolic issues, but nevertheless, it treats symptomatology very well, a lot of symptomatology very well. Not just the positive symptoms, but or hallucinations or delusions, but other types of symptomatology that come about in perseverations, obsessions, mood inequalities, that come about with these disorders, okay? And they added a samidorphan, they were looking at things like amoxicillin and things like that, so in the gut, and when they added samidorphan, I noticed that the metabolic side effects were substantially decreased, limited. This was approved in 2021, and we're in the last phase of the trial. We're out there with our patients, to see what the final outcome would be with the medication, which some were getting good results, and some patients, they're noticing minimal patients, not responding that well as if with the regular medication, but it's been overall positive, very positive. This is brexpiprazole, okay, and basically you see they've tried to include a lot of other receptors, partially D2 agonist. There's serotonin 1A. So now they're going, I'm not going to go too much into the psychopharmacology. It's not what we're doing today. But an example is we would adjunct other medications sometimes to treat a patient. So a patient has, and this helps because the patient has multiple medications on board. And us knowing psychopharmacology, what we're trying to attempt is, okay, we're giving one of the antipsychotic and then maybe another medication which targets this receptor, okay, in order to improve the executive functioning in the patient, in order to improve negative symptoms, and now it's embedded within the effects of the medication. Okay, and here as well, limiting, like before, you would use more that B, C receptors, and these you have to adjunct with other medications and now it's embedded within the medication itself. So it was approved in 2015 for schizophrenia as adjunct treatment for a major depression disorder, and recently, about a year and a half ago, around there, it has been approved for agitation due to dementia. So like we use sometimes antipsychotics, and they have a black box warning. This practically was approved to treat that. This one, brilaroxazine, it's a medication with currently it's in phase 3 trial. It's still on trial. It kind of like works similar to others, okay? But as you can see, trying to work also on other receptors, we can further aid on the other symptomatologies of these disorders, okay? Improving mood, function, blocking certain receptors like sigma. It can help executive functioning even further, motivation, and improve the negative symptoms. And they're showing improvement, in patients with acute schizophrenia. And when it says here compared to a aripiprazole, well, basically a lot of these newer ones, okay, like when they do clinical trials, they compare it to aripiprazole because it was like kind of like the first stemming on being a partial agonist of the D2 receptor, agonist antagonist of the D2 receptor, and they built from there to see, well, not going back to this, like what I said before, they're very effective, but they're very toxic. Aiming to compare it, and then you see if it's going to be a bit, if it's essentially better, then this medication can be approved. Taking on to them. Yeah. Oh, okay. Okay. So new compounds. So these are neurotransmitter. I already mentioned it. New compounds that predominantly affect psychotic symptoms for treatment of schizophrenia include these. Okay. For example, lumateperone is an antagonist at 2A receptor, that's serotonin 2A receptor. And in 2019, it was approved for schizophrenia and depression associated with bipolar 1 and 2 disorders. And it's being now tested also as well for behavioral disturbances in Alzheimer's. Pimavanserin, this is it has been FDA approved for symptoms of in Parkinson's disease associated with hallucinations and delusions. And know that I put associated with hallucinations and delusions. You gotta really delineate what psychosis is, and this is more so for that type of psychotic manifestation within the disorder per se. Okay, there's other symptoms that you might have to treat with, with other medications, but it has shown a great success for that. This medication is practically being developed, okay, roluperidone, and it's targeted, and its aim of this medication is practically just and solely to improve negative symptoms, right? That psychosis per se. And these are others that are out there, can discuss them, around clinical trials, but they're basically doing what I was mentioning before, polishing, getting to improve targeting specific receptors, epigenetic type of workflow, so it can help the patient a lot better in the future. So we're working to discover new targets, okay? And apart from now, when we're talking about the antipsychotics, there's also other targets, and not just for schizophrenia, a whole vast of psychiatric disorder, even substance use disorder, right? So we have the NMDA receptor hypothesis for schizophrenia. So they're in clinical trials targeting NMDA receptors, and this is something that you have to find a balance, like I tell everyone. This is not right. So it was a great advancement in 50s. Okay, so if you block dopamine, psychosis is going to improve. That's why we still resort to that, because it's a big component. It's a big component. Now, as we get more refined, what you really got to notice is this is a dysregulation in many structures, many functions of the brain. Dysregulation, not okay, you block this and that's it, we're good. No, it's dysregulation, and it's very hard, right? You target, for example, another specialty, not to, when you want, and you measure something, you say, okay, you give this is going to happen. And if this happens, this is going to improve. And you see it, you measure it, it's a 1-2 type thing deal that you look at. Okay, blood pressure dilated, or this is very complex because of dysregulation, and depending on the genetic predisposition of the individual, different, the way they express in the brain, the way they express within the disorder, not everyone is going to respond equally to the medication. It's not like, oh, we got this receptor and we're going to antagonize M2-3 and that's it, right? Well, it might not work for everyone, even with the same disorder. So a lot of it is trying to learn the disorder per se, understand it, and understand deep within the structures and functions of the brain. Glutamatergic system targeting, right? There's clinical trials with this medication. CBD is a biggie now. Everyone is talking about CBD, okay, and it has been shown that it's a partial agonist at the T2 receptor, okay. So it's been helping, like some of medications I was mentioning for psychosis and symptoms of negative symptoms, executive functioning, calming effect. And it's ongoing phase 2 clinical trial. The TAR, trace amine associated receptors, another target that we're aiming for to help with the symptomatology as well. And there's many others. Okay, long-acting injectables. Long-acting injectable is important, and they're a breakthrough. They're a breakthrough because even other medications are coming out for substance use, for like HIV, many others that stemming from the way that they were created, it's having other uses other than for mental illness. And long actings are important because one challenge that we encounter in psychiatry is poor compliance. Okay, that's a big, getting a patient to comply can be very difficult. Okay, can be challenging, especially younger at any age. But they don't want to be on medications, and it becomes a stressor for everyone, family members, the patient, and ourselves. And sometimes it's due to lack of insight. Sometimes can be good insight actually, and I don't want to feel a certain way, but the lack of insight of the disorder. That's why it's important to talk to patients. And the long-acting injectables were first developed in the 70s. Okay, so we had first, oral medications, and seeing that this was such a challenge, we say, okay, what are we going to do, right? So we come up with long-acting injectables, which are less refined than the ones we have today, even though effective, but less refined, more side effects, and they even hurt even more when you get the injection. In the 70s and the 80s with Haldol, fluphenazine, Elixir in the 70s, and so on. There's a more first generation antipsychotic, long-acting, and here we start to create, actually around here, the second generation ones, right? And then we go into developing those who are a little more refined further on. Okay. So like I just said, non-adherent, non-compliance is a big factor that we resort to using long-acting injectables. This provides a continuous delivery of the medications in the blood, and And as we got a more refined and a more steady state pulsatile manner, right? And currently we have 9 second generation antipsychotics on the market being FDA approved. They also help with reducing relapse. Why? Especially in the more refined ones now. Okay, so a patient misses a dose. There's already some medications that have been created, which will stay in the system longer than what the label says, right? So it's okay. It's it's a monthly injection, right? But in reality, it'll stay a little longer in the system for the majority of individuals. Not all, some can metabolize it a little faster. Okay, we're coming up with formularies that are I'll touch upon now. Formularies that are not just monthly. It can be given every 2 months, every 3 months, every 6 months, and it helps the patient, right? I have a patient that it's a challenge every time it comes every month. Nevertheless, he wants to come every month, but doesn't want to get injected every month, right? I mean, it's a big show. So, doing that every 3 months, it helps. It helps everyone, and it helps to assure the compliance of the patient. And it has been shown in statistics that it will decrease rehospitalization by 20 to 26%, and it's due to that factor I just mentioned. Okay, so recently developed long-acting. So we've used from a little bit from some time now near the aripiprazole, in pain, and it's a very good medication actually. But they've come with other type of molecular structures, right, where the medication will last longer. The medication, for example, on this one, they created aripiprazole lauroxib, and what they did an adjunct to that, in the recent years, is approved one that comes that is a pen, it's a nano, and it has a nano crystal, right, large crystal. So that one, one of the great things that it does is that once the patient is ready to give the injectable, on that day, you give 1 dose of the oral medication, you give the nanocrystal one, okay? And together, after that, then just right one after the other, you give the long-acting, whether it's for a month or 2. This one comes for a year, a month or 2. And the great thing about that is that when you put somebody on a long-acting injectable, there's a period of time that you have to keep them on oral medications, right? As first the medication it starts peaking in the bloodstream, in the system, and getting into blood, and then when it reaches a peak in a steady state. While that's being done, you have to be compliant with oral medication, because if not, it's not going to work appropriately, and the patient can relapse. With this strategy, and you put that little mini injection, or pen injection as well, it limits the use of the oral medication, because automatically within hours starts going into the system, okay, and it acts as that gap between the oral medications. It's like you having the oral medications, but within the system itself, as the long-acting injectable that you're gonna be taking regularly starts to work. We also came with breakthroughs such as the first subcutaneous long-acting injectable, right? A form of risperidone, extended release, and instead of having to inject the patient intramuscularly, basically you put a subcutaneous, sort of like the nanocrystals. So with that, you have to experiment and work with certain molecular structures where instead of going in the muscle or going to the subcutaneous tissue, and then from there start getting released little by little, progressively for the patient. One of the challenges with this medication is that, and that's why this came out. One of the challenges, it works well, but one of the challenges is that it's for patients who total a day. If you know risperidone has a max dose of 8 milligrams per day. The FDA label, right? You can go above in some instances, but this long acting is more for patients who require a total of 4 milligrams, 3 to 4 milligrams. It comes in those two doses, the long acting, 9120, but for 3 and 4 milligrams. So if you're a very severe patient requiring more doses, this ain't gonna work. It's not gonna work at all for that aspect. So they're trying to come up with this medication, which is currently in clinical trial, which is an in situ microparticle, okay? But it's intramuscular, right? But it has this in situ microparticle stay and start liberating immediately within 2 to 6 hours the medication in the system. So now you don't got a need for this, right? This is a different type of medication, right? It's another antipsychotic, but here you don't have the need that automatically start going in the system. And in Europe, it's used. Here, it's undergoing clinical trials, but in between, somehow they ingenious to come up with this formulation, right? Which is a risperidone extended release, which is subcutaneous, right? As well, subcutaneous. And it has a steady state technology, right? With a copolymer formulation, right? So what that does is that it's given subcutaneous. It just recently came out on the market now in 2023, April. And what it does is that within several hours, okay, after being injected, subcutaneous is not need to go intramuscularly. They start getting released into the system. No need for oral. No need for something like this. And it doesn't have to be so invasive. So let's, it's interesting to see where this is going to go. And like I told someone, let's see, they're going to have to elaborate something substantially better in improving symptoms and limiting side effects if it's going to go out there. And like you said, a lot of these have more prolonged extended release, even through months out. Okay, so other pharmacological agents. Let's talk about antidepressants, right? For example, we've had in the past SSRIs, or I give you a little bit of history, then we developed some SNRIs, serotonin norepinephrine reuptake inhibitors. This created more so because previous medications, like tricyclics and inhibitors, right? They work. They work, in fact, better than these medications, right? But what's the situation with that? A lot of side effect profile. So we started elaborating newer medications the same way that we're doing other things to limit side effect and for them to be effective, okay? See, so it's demonstrated to have effect, but still, there's a 30% that show no response to these type of medications. Now we're building more so like multimodal medications, antidepressants, ibuprofen, right? It's a new class of multimodal mechanisms, right? So actually on serotonin transporter inhibitors, right? So it's sort of like an atypical but more refined. An atypical antidepressant, more refined. Brexanolone. So it's this came out. I remember when this came out. We're trying to do it within our institution, but this is kind of like more so you have to have a setting, like a maternity or medical floor kind of setting to do this. This cannot be done in a psychiatric ward. Okay, the patient has to stay several days, and basically it's a progesterone metabolite produced by the brain. Glucan placenta, you replace it. Is FDA approved, right? So hormonal imbalances. This is I'm sorry, I forgot to mention. This is used approved for postpartum depression. So postpartum depression, we might, I don't know how much you guys have research, but it can be very devastating. It can be very devastating, and it affects a vast majority of individuals as well, and quality of life, they, family, and it can evolve to getting worse. So this was approved in 2019. Like I said, administered intravenously, and it has to be observed over a 60-hour period. Zuranolone. So this is an oral agent. So this is just developed now in August, and in comparison with this can be done just in a 14-day period, oral form. The patient can go, right? And a lot less risk of monitoring and side effects and stuff like that. Let's see how it works. It has a lot of promising. Glutaminergic system, with the group R5, which is this is trying to attempt to mimic the effects of ketamine. Okay, and this so it's ketamine is a biggie now, and this is sort of like getting that PEP anti mood properties. Okay, basinglutant. Okay, and it's in clinical trial for major depression. And ketamine, okay, so basically being used for treatment-resistant depression due to what I said, its mood elevating properties. Okay, so this one, BASIMGLURANT. Yeah. So emerging therapies. Okay, so we got the ketamine we're talking about. So a little bit of history, just a brief little history. So PCP, okay, it was used, as an anesthetic around the 50s. Okay, the problem with PCP was that when patients were coming out of anesthesia, they were getting dissociative symptoms, sort of like a psychotic symptoms, and things that were causing the patient, delirium, dissociating. So, hey, what do we come up with? What do we do about that, right? So, in 1962, right, ketamine was synthesized, right? Paul Stevenson, the research and anesthetic, to replace it. It had its first human trials by Dominguez and Dr. Dominguez in the first studies, with humans in 1964. This was mainly done with inmate population, which we're going to be doing back then. But nevertheless, it showed promising results. It showed great results, with them. But the actual trials were in the 70s. And once it was, FDA approved for as an anesthetic and analgesic, which later on just as an anesthetic was taken out because of a lot of other issues that they noticed with the medication. It has to be more controlled. But it was to treat soldiers in the Vietnam War. So since it doesn't have to be so controlled in the effects that it actually peps up your autonomic response, you don't have risk for intubation. You don't have to be in a controlled setting. So it can, when you see a movie from Vietnam War and things like that, you see the soldiers and kind of, they lose a leg or something, and you see them that are injecting some form of medication. But this time, we're not using opioids or anything like that. It was ketamine. Okay. It was then confirmed in 1983 as an NMDA receptor antagonist, right? So we saw that we can use this for mood disorders and a lot of other disorders, right? Start, lighting a bulb. And then it stayed, basically, we started using it more intravenously as an anesthetic. Here, they was noticed that it can be given intramuscularly, right? Here we're using an IV forms as an anesthetic. In the 2000s, we had first double-blinded placebo-controlled trials with the bulls, with the ketamine, the RNDS type. And in 2019, it was approved by FDA with a permission for the S part of the ketamine because the other has a lot of risk, and separated from the ketamine molecule, the RNDS type, and we're using now the S type as a nasal spray to treat treatment-resistant depression, as you guys know, as Spravato. It gives you a dissociative. So I already said this is structurally related to PCP, and it's described as a unique drug, right? Because it has a combination of hypnotic, analgesic, and amnesic effect. It is a racemius mixture, like I said. I already explained that with the two enantiomers, and it is also an NMDA receptor antagonist. And it's currently in Schedule 3 controlled substance FDA just for an anesthetic. Like I said, they took out. That's when the opioid crisis came out, right? And say, oh, this has to be non-controlled as an analgesic. What do we do now? Opioids. And off-label uses, it's used for pain management, off-label out there, it's a great pain management medication. It's great for mood, regulating mood and things like bipolar disorder, not just elevating mood, and anxiety and post-traumatic stress disorder is showing great promising results. What's the future? Okay, the antidepressant potential, right? They, can possibly become first-line treatment, right, for depression, right? Especially treatment resistant, right? If we're using, once we improve even with further elaboration of molecules to work with or settings, and it's a rapid treatment for suicidal ideation. Okay, it's used in some emergency departments. Even it's being used on ambulances for substance uses, intoxications, and overdoses, and suicidal ideation. Right. Pain management is effective in reducing morphine requirements. Right. So that's important. It's a big thing for us to really look into. Right. So we're trying to limit the use of opioids. And, nevertheless, somebody comes out of a surgery and they're in a lot of pain. And we all respond differently to pain. So if something can be adjunct to try to limit, the use, the days, the exposure of something that can be addictive, it can substantially help, right? And then also, post-operative nausea and vomiting, where, give somebody an opioid, that's exactly what's going to happen, right? It's one of the side effects. Alternative for acute and chronic pain in the long run. Yeah? And in trials for PTSD, a combination with ketamine and psychotherapy have shown a great reduction in symptoms in PTSD scale, that is used. So it's shown that, together with that, the symptomatology. And even as an anti-inflammatory effect, right? Local and general anti-inflammatory has been observed. Let's see if I can explain them in the other slide. If not, I'll explain here. And it opens door to new applications, right? Like I said, and ongoing research with full potentials. So the anti-inflammatory effect, irritable bowel syndrome, some problems, and a whole area of anti-inflammatory, I think one that you can calming the nerves, the inflammation will go down, and have some embedded anti-inflammatory properties. This is Spravato, right, which is, like I said before, the enantiomer, the S-enantiomer, and it's for treatment-resistant depression. It has to be at a control setting, though, right? The patient has to be there for several hours. It has to be monitored by a healthcare professional, a nurse, the doctor. And major depressive disorder with acute suicidal ideation in conjunction with oral antidepressants afterwards. And like I said, a controlling pattern. Let's go now to psilocybin. Psilocybin and psilocin are a tryptophan indole, and tryptophan, it's something that it's like a precursor for serotonin, for melatonin, for things, dopamine, which helps regulate your mood in the brain. This was derived from mushroom, okay, from the genus psilocybe, okay, and all of these here, I see. And the history is, magic mushrooms have been used for various years, right? Globally, shamans, certain cultures with religious ceremony, and Dr. Hoffman, synthesized it. Was seeing that and synthesized it as a prodrug, psilocybin, in 1957 from the mushroom. It has psychedelic therapy models and intensive research, between the 50s and the 70s, and the research halted due to Schedule 1 classification of these others, which kind of like have the same properties. So it's LSD, PCP, all of that, and then everything then was, everybody paid, as a result, and it was taken off and the market and put a Schedule 1, for use, and prohibited use in 1970s, because there's a very thin line of how some of these medications can be a positive effect towards the patient, towards a detrimental effect and addiction. In the 21st century, psilocybin has come back into a world of psychopharmacology, and clinical trials have resumed with promising results. And investigators are using it for addiction, depression, post-traumatic stress disorder. There's certain clinics, very, very few in the United States entirely, that are using it now. You're seeing more of individuals wanting to engage with this. This is a great thing, and I'm very interested. And basically, this is how kind of like it works, right? So it metabolizes, you know, to lipophilic psilocin, right? It stimulates BDNF, which is actually it helps with the growth of neurons, regeneration, right? It goes and works here to improve executive function and motivation, and decrease learned helplessness, and affecting the prefrontal cortex. And there you're going to have neuroplasticity regeneration. Like I said, it goes and works on these serotonin receptors, you know, activating them. It can be a psychoactive hallucinogenic effect. If you go beyond, if not, you're going to release some dopamine, or if you have certain disorders, so it's not for everyone, right? Release of dopamine from the striatum, and then you have a regulatory effect on pathway. Like I said before, it's a dysregulation, not right. So this is really promising. It can regulate, right? It downregulates some of these effects of receptors, which at the beginning can precipitate or worsen symptomatology, right? So it gets saturated, and you know, compensatory mechanisms work and glue, right? Like we're looking into other substances and other medications that we're elaborating. This it upregulates itself as well. It releases glutamate from the prefrontal cortex, which, like, kind of like what I mentioned here, you know, improving the function. You know, I think that for, you know, negative symptoms now, we got to work it out. Or really treat psychosis, right? Or make it worse if you go too much. And mediation of craving for addiction, right? And cognitive function, and improve cognitive function. Okay, so these are trials that has been done here in 2020. They conducted 17 trials, right? And basically with psychedelics, right? All of these, as you can see, and it's aimed for reducing depression and anxiety, you know, and comparable to placebo. Here it says comparable to efficacy to SSRI. We're also seeing comparable efficacy, some beyond, but the actual advantage of it is that you're going to have to sometimes take medications forever, for a long extended period of time. Maybe with 3 sessions of psilocybin, you know, you resolve the disorder or the symptomatology, right? Or it doesn't, you know, sort of like it doesn't come for years or resolve it completely. Being used on cancer patients, you know, studies, you know, showing potential in reducing depressive symptoms and anxiety associated with a terminal diagnosis, the disorder per se, doing that, the disease. Treatment for addiction, you know, currently FDA approved for substance use therapies, you know, have modest effects on effects and risk of relapse. And it has encouraging results, especially for nicotine and alcohol use. Okay, nicotine is very addictive. You know, we're down, but it is. Okay. And here, and I want to touch on that. You know, the rest not a big deal, but you can see here that 80% of patients were abstinent, you know, after a trial of, you know, a course of psilocybin. After 6 months, 60% of participants were continuously abstinent throughout the 6-month period. And in follow-up, 60% of participants were continuously abstinent at 12 months, and 75% of participants were long-term abstinent at follow-up, even at a mean of 30 months. That's promising. And here we can see it with an NMDA-assisted therapy, which is different, you know, for PTSD. Okay. So with NMDA, you know, known out there as an abused drug as ecstasy and Molly, it has a moderate to severe PTSD, for moderate and severe PTSD when combined with specific psychotherapy and for that. Okay, so the study what did actually is they got now in September 2023 they got 104 subjects, and you know, some of the subjects were given placebo and psychotherapy, and the other group was given NMDA and plus the psychotherapy. Okay, and when they did their PAP-4, which is aimed to see the symptomatology reduction of post-traumatic stress, is noticed a bigger trend, you know, after 1 session, 2nd session, 3 sessions of the symptomatology compared to the placebo and therapy alone. CBD, cannabinoid. Okay, so let's go. The plant cannabis sativa, right? This is complex because it has a lot of chemicals within it. It has 400 chemicals, and to elaborate a medication to target certain things can be challenging, very challenging. And approximately 80 of those are biological, 80 to 100 are biological active. And psychoactive compound is the THC, as we know, from the marijuana plant, and particularly the isomer delta 9, THC, and it's other identified compounds within it is the cannabinol, the CBD, CBG, CBN, and others along with that. The properties are non-intoxicating, when it doesn't have the component of THC, and not psychoactive, right? So you take that component out of the psychoactive. So the analgesic and anti-inflammatory, it has analgesic anti-inflammatory properties. It inhibits it's a COX inhibitor, just like budgetary inhibitor, right? So patient have to be careful with your stomach, right? But it decreases inflammation substantially. It's been used even like for post-COVID syndromes and things like that, where you have chronic inflammation, and it's shown great results. It has antiemetic, anxiolytic, antipsychotic, the CBD alone, per se, like what I discussed before, and neuroprotective and antioxidant properties. Right? And the antioxidant, properties, and preventive properties. I remember years ago, about 10 years ago, a study coming out, which is still ongoing. I mean, this is something, that it needs time. It needs time to research, where in Alzheimer's patients, with only like a 0.3% of THC within it, it shows promising result in decreasing amyloid plaque and functional ability in patients with Alzheimer's. Okay. There are 3 FDA-approved synthetic cannabinoid drugs, right? Dramamine, right? Marinol, we use for anorexia, like passion, and stage, so they can stimulate appetite. Nabilone for nausea and vomiting associated with anti-cancer therapy, and epidextrone, FDA approved now in 2018 as for kids. It's more like a childhood seizure disorder, like Lennox-Gastaut syndrome and Dravet syndrome. It's under investigation for various psychiatric and neurodegenerative disorder, inflammation, like I mentioned, and even for mood disorders, control of pain, and inflammation, like I just mentioned. And it has also antimuscarinic properties. Let's go into brain stimulation therapies. Wrap up. Here we are going to talk about ECT, electroconvulsive therapy, transmagnetic stimulation, vagus nerve stimulation, and deep brain stimulation. So electroconvulsive therapy, okay? If you're old enough and don't even say it, you might remember this movie, in the 70s, one under the Cuckoo's Nest, and with Jack Nicholson, and they're it's introduced at how barbaric, right? Is how barbaric it is to do ECT. In reality, it's not. It's a very safe procedure, okay, and it has a great effectiveness, right? So it when it passes a mild electrical current, right, through the brain, right, and maybe early 20th century and things like that. It was less refined machines, but by now this is very safe. The current passes through without any damage, and it induces a little short seizure, right, where it reboots the neurons, and it has to be done in an OR, operating room under anesthesia. The mechanism action multifactorial, go forever on that, and it causes change, but it's substantial that it causes changes in blood flow and regional metabolism in the brain. It's been around for more than 80 years, prior to the FDA. I already mentioned that, the portrayed in movies and media, and in early treatment, it was lacking anesthesia. So imagine somebody undergoing this with a less refined machine with a current that is not so well managed without anesthesia. That's when you have to put the something for the patient not to breaking, still we do, but, the patient's, you're holding the patient. And early treatment will reduce, significant injury, and that led to stigma. Patient and family education, it's important, telling them that it's safe and under anesthesia and is performed by a trained professional to decrease that stigma. Indications. In 2018, the FDA reclassified CT from a device that is a class 3 to a class 2, and even in some instances in a class 1, really less invasive or risky. You may say it that way. And it's being used for severe unipolar and bipolar depression episodes, maybe depression with psychotic features, schizoaffective, bipolar, whole, and like the malignant syndrome. Sometimes, patients have to resolve and you have to run, and it can be life changing, it's like any symptoms, and as per se it is, catatonia, to treat catatonia, which can be something you can treat with medication, but it can become and chronic, but it can be life-threatening as well. Suicidality, severe psychosis, and someone just shutting down, through severe depression, which is not eating, and it has a safer profile than antidepressant or antipsychotic in non-specific patients. You guys get it. A lot of step 3, right? A lot of pregnant women, yes, really safe. Breastfeeding, debilitated, elderly, yes, you can use it. It's safe. It's a safe procedure. Under a really well-trained professional, right? Low mortality rate in control settings, right? Long-term, what it can have is mild long-term memory loss, right? And then may occur. We know it for a while. There's certain institutions that engage in ECT, really high-end and good ones, which actually are using a lot of scales to monitor. They're doing 200 ECT sessions, and ongoing for a patient, and they're actually doing scales monitoring the progressive amount of memory loss after doing the procedures. It has an antidepressant effect that acts quickly, and may lead to years, right? It can be, they don't have a relapse in 10 years, maybe more, maybe that long, right? In patients with severe treatment-resistant depressions, for example. Suicidal ideation and release it rapidly, right? That's why we come up with that term before, because you can use it, even though it has to be controlled, but with this, it has to be, a lot more controlled in the sense of, an OR, the sociologist, the whole work. And it has a complete resolution. It's been observed from suicidal ideation 38% after 1 week, 61% after 2 weeks, and 81% after completion of the sessions, of ECT that you're scheduled for. Transmagnetic stimulation. You guys want to get this really in depth later on, but it's a non-invasive technique that uses magnetic field, so less invasive, that the ECT, and it stimulates brain regions within the brain. So depending on what the patient has, and you put the electrodes and you aim targets at what you're treating, right? In 2008, it was approved by the FDA for treatment-resistant depression. In 2018, for obsessive compulsive disorder, and so on. It's been approved for migraines, for smoking cessation as well. Off-label, it's being used for all of these, neurocognitive disorders, mood disorders, eating disorders, essential tremor, and fibromyalgia, Parkinson's. I remember when it started coming out, a lot of experiments were being done with Parkinson's patients, and it was promising. Post-traumatic, schizophrenia, so a whole ample road of off-label uses. Vagus nerve stimulation. Okay, so vagus nerve stimulation is a device that's placed to stimulate the vagus nerve, right? Which basically is working in the parasympathetic system. And with electrical impulses that travel to different areas of the brain, this helps with different disorders, right? It was even used for epilepsy as early, it wasn't such a refined apparatus, but in the 1880s, as early as that. In the 1930s, I noticed that there were EEG changes being noticed, on patients that were experimented with the vagus nerve stimulation, and various animal models throughout, the centuries were done. In 1990s, started conducting clinical trials, more so in humans, more intense. And in 1997, it was FDA approved for the treatment of refractory epilepsy. And here you can see vagus nerve is a large nerve, but there's different areas that is implanted depending on what is going on with the individual. You have here. So, like I said, FDA approved in 1997 for epilepsy, in 2005 for treatment-resistant depression. And what happened is, in these individuals that were being treated for these two disorders, they started noticing that they were obese. They were losing weight, right? And say, okay, what's happening here, right? Whoa, let's do something. Something must be happening. Passes all through the gut, and eventually from that, I noticed that it does work, and it was approved for obesity in 2016. Okay, and there's an invasive form, non-invasive form. You can put the apparatus outside and just target, that form outside, and or within implanting the device. Okay, and the non-invasive is the approved for migraines and cluster headaches. What's the future holds? A lot of inflammation, like the other that I was mentioning before. Some of the other substances I was mentioning. So for irritable bowel syndrome, right? So colitis, Crohn's disease, rheumatoid arthritis, diabetes, Alzheimer's, right? There's there's been theories that due to sorcerers or prions, and maybe a prion, walking up, the prion and going up the vagus nerve and affecting the brain, right? Well, at the end of the day, it's anything that causes inflammation, but it can decrease inflammation, calming by stimulating the nerve, calming the parasympathetic, the autonomic nervous system. Let's put it that way, because you get activated in the gut with the parasympathetic system, depending where you're going up here, and it can help. I've been a lot of studies even that I've read helping in decreasing stroke, heart disease, on individuals due to that mechanism of action. Deep brain stimulation. This is a neurosurgical procedure which implants electrodes to specific areas on the brain, right? You plant a little thing inside the brain structure, and you connect a pacemaker-like machine, right? And it has a pulse generator on the chest. The evolution of deep brain stimulation technology in the 50s, it was identified, in the structures via intraoperative stimulation, right? So it was done there. It's not that it's gone and you can go. It was, you get the individual, open the individual up, and it's basically being done actively. Then you go. Now, what are we going to do to keep that in place, right? Let's create the device. So in the 60s, the theories of treating neurological disorders, led to the implantation of chronic, or elaboration of theory of chronic implantations. In the 70s, it was documented managing pain, movement disorders, epilepsy, and through chronic stimulation ongoing. In the 90s, the combination of implantable pacemaker technology with chronically implanted electrodes enabled the discovery of the deep brain stimulation, right, of the device. In 99, the first psychiatric indication for it was published, okay, and we'll go into that now. And it's initially used for, and this is the target that mainly implants within the midbrain, mostly the subthalamus nucleus, the pollicis pallis interna, ventral intermediate nucleus of the thalamus. So it's more, striking on deep brain, midbrain structures. So helping with essential tremor, right? The filter of the brain, coming from the cortex. So let's help with those symptomatology. Essential tremor, approved in 1997. Parkinson's disease in 2002. Dystonia, okay, chronic reactions which actually happen and stem from those areas in 2003. And treatment refractory OCD. So it's used also for obsessive-compulsive disorder. The structures that it's targeting will go to the orbitofrontal cortex, and it's limiting that from happening in the obsessions to the recurrent source. So it can be a promising in the future for even substance use, and a lot of these off-label use, right? Addiction, autism, right? Which have that kind of preservative kind of same, similar, let's say, a pathway and symptomatology. right? Anorexia, anxiety. I remember once I was in a nursing home and a patient, everybody thought it was a medication they were giving. There was something wrong with the patient, and stiff and all that. And what happened was, during the hurricane, it got flooded. They found the gentleman, on the floor. And the thing is that the device that comes with it, to send the signal to the electrodes, to the implanted device, was damaged. And I was trying to get him an appointment. All he needed was an appointment to fix the thing. We finally did, but you should have seen him. Once this was fixed, it's amazing. He walked out, no tremor, no shuffling gait, like someone that didn't have any Parkinson at all. So I saw it firsthand, not seen it firsthand several times as well afterwards, and it does work. It's a good thing. And I think that's it. Thank you. The diet, yeah, diet always helps. Diet always helps. I mean, I incorporate it in my practice, teaching them, and ketogenic diet does big time. Okay, staying away from like starches and carbohydrate, things that will cause inflammation. A lot of understanding a lot of how these things are also happening is, it, the mental disorder per se, having inflammatory properties, right? There's an individual inflammation, also worsening that, right? And having a ketogenic diet, even for dementia, Parkinson's, right? For example, some patients, give them a spoon. Now they're coming with better number four, just get organic coconut oil, right? Now you get they come in more refined, in certain oils that just extracted when it comes into you are going to really help, right? With that. So adhering to a good diet and a ketogenic diet absolutely does help in conjunction with these things incredibly. Is there any landmark studies on that? There is. Yeah. Yes, there is. There's a lot on it. Right now, we give you the name, but I'll find it. Yeah. But I've read multiple ongoing studies. We have attempted to do it as well. And even vitamins, right? So in vitamins, if you have somebody that has on the lower end of a vitamin B12 level, for example, right? But it's within normal limits. Yeah, why you replacing it? Because that individual with mental illness can predispose him. For example, bipolar, schizophrenic, like that, right? And at the same time, will help the medication work faster. And with the ketogenic diet, decreasing inflammation, right? And type of diets also helping the gut, right? That's why the vagus nerve, right? Helping the gut, and microbiota, which in conjunction with a ketogenic diet, the inflammation will go down substantially, and the patient will improve greatly. Absolutely, yes. Mm-hmm. In the acute setting, it's challenging. Why? Because it's an expensive medication, right? So it's not a medication that is. They're trying. In fact, I have the drug resident coming to me, right? Yeah. They're trying and work on programs. The company has to do that as well, right? On programs to be able to facilitate, right, the use, because it's expensive, right? Although it's expensive, and it's a newer medication. So in the acute setting, it becomes more challenging. But I think that where you're going also is it'll be effectively that fast, right, towards treating. Not really. I mean, you will put the patient on, and they'll tell you, yes, it'll start working pretty immediately, pretty fast, and you'll see results. And those are, but in reality, sometimes you have to use more conventional medication, to attempt to resolve an acute agitated state, right? Yeah, it won't work that way. No. Not that much, not that well.
So thank you so much, Dr. Ferrer. This looks like an exciting time to be in psychiatry. So I envy you guys as things begin to change. So thank you so much. And I think we'll move on to Dr. Michelle. Dr. Michelle is the founder of Larkin University, which encompasses a college of pharmacy, offering a 3-year PharmD degree, as well as the College of Biomedical Sciences, which provides master's degrees in biomedical sciences. He additionally established the Larkin Health System, an accredited integrated healthcare delivery system with locations in South Miami, Hialeah, and Hollywood, Florida. This network of hospitals offers a comprehensive range of healthcare services, including inpatient and outpatient care, home health agencies as well in both Miami-Dade and Broward County. Larkin Health is the 6th largest teaching hospital in Florida based on the number of postgraduate training programs, and the 4th largest based on specialties addressing supply and demand deficits in Florida. They offer postgraduate training in more than 40 medical specialties, including programs in advanced education in general dentistry, the American Society of Health System Pharmacists, an accredited pharmacy residency, and a podiatric medicine and surgery residency. A Larkin School of Nursing also provides a registered nurse associate's degree program, and Dr. Michelle serves as the Associate DIO for Larkin Community Hospitals. Welcome, Dr. Michelle.
Thank you, Dr. Echols. Can you guys hear me?
Yes.
Okay, perfect. So the topic of this lecture, actually, I'm gonna pause the recording so we can start all over again.